Associate at the Policy Research Unit in Palliative and End-of-Life Care here at the Saunders Institute. I'm covering today for Therese Johansson, who's supposed to chair the meeting, so I apologise for any mistakes in advance. Without further ado, I'd like to briefly introduce our speaker and then hand over to Liz. Today we have Professor Liz Forbat. She's a research psychologist at the University of Stirling and family systemic psychotherapist in her independent practice. She's been leading research on serious illness, caregiving, cancer, and palliative care for over 20 years. Today's talk is titled Improving Dying and Death in Care Homes, the Evidence of Palliative Care Needs Rounds. And in this session, Liz will describe the use of the Palliative Care Needs Rounds as a method of systematically providing high-quality specialist palliative care to care homes. We'll hear her present evidence spanning over 9 years from Australia and UK and outline how the approach meets practice and policy needs. We would like to ask people to keep their cameras on if that's something you're comfortable with. And I will hand over to Liz now. Liz, are you happy to share?
Yeah, okay, thanks so much. And thanks everybody for joining on this Wednesday afternoon. So I'm happy to do this quite informally. So if people have got questions as they go along, sling them in the chat, that's fine. And I know our moderators are going to very kindly keep track of anything that I miss in there, but really happy for this to be a bit dialogical if that's going to make it more engaging, because I know it's weird and hard kind of staring at a screen and trying not to get distracted by other things that are kind of yanking you in other directions. So I'm going to talk a little bit about palliative care needs rounds.
Liz, apologies for interrupting. Can I just check if you're sharing anything?
I'm not. I'm just going to cue that up. So that should be perfect, just in a moment on your screens. If you let me know if that's come through now.
We can see it, but it's not in the presentation mode. We can kind of like see the outline of the PowerPoint.
Oh, that's weird. Okay, I'm going to stop and try again then. Right, what's it done that time?
We can just see the slide and nothing else, so I think it should be okay.
Okay, all right. Well, as long as you can see the slide, that's the key thing. Is it kind of big enough to see on whatever device you're looking at?
For me, it is. Yeah.
Okay. Okay.
Yeah. Well, and I can see thumbs ups as well. Yep.
Oh, okay. Oh, that's really helpful. Thank you, whoever that was. Okay. So, yeah, I'm gonna talk a bit about palliative care needs rounds and give a bit of a sense about where they've come from, what they involve, and then about the evidence base. I'm presenting from University of Stirling. You can see the campus behind me in my fake backdrop. But this work has been conducted all over the place. So I'm going to be drawing on evidence from Australia as well as Scotland and England, and there's growing evidence from other places too. The work that we've been doing, particularly in the UK, we've had quite a lot of patient, public, lay involvement in the work. So I just want to give you a moment to think about what impact that has on the kind of validity and the impact of what we've been doing, as well as people with who joined research teams as people with lived experience of care homes, as relatives. We didn't ever manage to involve people living in care homes as kind of co-researchers or in the research team, but as well as having 3 people join the team as kind of members of the public, many of the research teams have also relatives living in care homes. My mum's currently living in a care home now in England. So it's a project that's very much grounded in understanding and believing and feeling very deeply how important it is to fix how well people die in care homes. So let me just say first off what needs rounds are. So they are an approach to improving care within care homes. And now I've got that slide. I'm wondering if I've got the right ones. No, this is not saved the right version. So I should say I switched computers yesterday, and I'm having real sync problems with my OneDrive where everything is stored. So this is not the most up-to-date set of slides that I polished yesterday. So apologies for that. So this is going to involve a bit of reworking in my head about what path we're going to take through this afternoon. So let me tell you about what our needs rounds. So they've got three components, and you can see those three up here on this slide. So initially, and the core part of them are monthly triage meetings, which are held between clinical staff, some people from the care home, and then somebody from specialist palliative care, typically from a hospice, where they meet together in the care home once a month and talk about residents where they are most concerned about people dying without an adequate plan in place. So they're staff only. It's triage meeting because they're not going to discuss every resident within the care home each month. They're going to think about who is, like I say, most at risk of dying without a solid plan in place. You can see from the bullet points there that during these discussions, you trot through biopsychosocial, spiritual concerns, and talk together about what other plans might be in place, including future care plans or advanced care planning documentation, power of attorney, and those kind of things. While that conversation is going on, what the specialist palliative care clinician is going to do is to weave in a little bit of education based around the cases that are brought. So if we're in a needs rounds and the staff are saying, we want to talk about Margaret, she's 88 and she's got COPD and osteoarthritis, we're worried about her changing cognition status, and she's also got pain from advanced cancer. So the palliative care clinician is going to be hearing that, taking that on board and thinking, well, what from my experience in palliative care can I help the care home staff learn a little bit more about? And we'll weave in a little bit of case-based education on one of those things that's been raised about the residents' status and well-being. In those meetings, we anticipate that they would be able to talk about several members of the care home residents. Less than 10. 10's a real stretch because these meetings only last an hour. So that obviously doesn't give much more than sort of a 5-minute quick shot of each. So in the UK studies, we were looking usually about 4 or 5 people. In Australia, it was typically 7 or 8 people that were discussed in these monthly meetings. The second part of the model is whether or not at the end of that monthly meeting, there is a need for some sort of referral. And quite often that might be to specialist palliative care, so referral perhaps to the hospice for particular interventions, or to external referrals. So that might be speech and language therapy, dementia support teams, those kind of other external organisations and professions. The third bit, you might call them case conferences, or they might be multidisciplinary team meetings. But typically that, again, would pick up on anything that came out of those monthly triage meetings to think about, well, what do we need to do next? So do we need to pull in, for example, a physiotherapist or a speech and language therapist with somebody from primary care? Or do we want to pull in or invite in, not pull in, invite in, say, members of the residents' family and to talk to them about whatever was discussed and maybe think about what their needs might be in terms of communicating and understanding what's happening next. Needs rounds follow a published checklist, and I'm going to come on to that later on in a few slides' time. Who knows where, given that this is not the PowerPoint that I was hoping to present to you. And absolutely, I can see Joanna's asking in the chat about the recording, so I'll leave it to Emil to describe where you'll get access to that, and I'm happy to send the real slides, the proper slides, to you for reference as well. Later on, I'll drop in a link to our website, which contains all sorts of resources too, so you're welcome to have a surf through those later on. Okay, so that's essentially what needs rounds are. 3 components. There's a big emphasis on that first one, which is the monthly getting together of people that have a stake and interest in improving care in care homes. Now, one of the sadly missing slides is about why this is needed. So we know that care in care homes in many ways is beautiful. We have staff in care homes that genuinely care about the residents and that are striving every day and every shift to look after people with dignity, with comfort, and with fun and energy. And we know that often that's really lovely. But also, we know that people aren't necessarily getting access to specialist palliative care in the way that they would if they were living in their own homes and communities, particularly those with cancer, given that we know that still in 2025, most of our specialist palliative care delivery is to people with advanced cancers. But nevertheless, people in care homes, it is often the last place that they will live and often the place that they will die. There was a paper published in, I think, 2019 by Anne Finucane and Anna Bone, looking at place of death, and that care homes is by 2040 is going to be the main place of death. I think that equals dying at home, hospitals dropping way down, and palliative care still hovering at around the kind of 4%, but 4 or 5%. But by 2040, about 30% of deaths are going to happen in care homes, another 30% in people's own homes, and that statistic is likely to keep increasing. So getting it right in care homes is really important, and that is what drives the research that I've been doing, is knowing that it's not okay that people's deaths in care homes may not be as well managed or well supported as they would be in other places. Some research conducted by Marie Curie in Wales and in England, again several years ago now, but I don't think things have changed at all, showed that mostly the links between care homes and hospices was very ad hoc, and it was very reactive. The idea with needs rounds is that this is proactive. Every month you're thinking ahead, who might we need to talk about to enable us to get things in place? So that's been the massive driver. So it's really about complementing the expertise and the lovely primary palliative care that goes on within care homes already. I mentioned the checklist. I'm going to zoom in on this in a second because I know that'll be too small for you to see. I mentioned that palliative care needs round to follow a checklist. So we generated this checklist through some research, through some ethnography in Australia, where we were initially developed and then ran the first randomized control trial on needs rounds. This comes from an ethnography that preceded the RCT and enabled us to think about what typically happens and how do we help structure these discussions, these monthly discussions in particular for staff. So you'll see there now then, is Liz going to be able to zoom? She is, hooray. So you can see there at the top of it that there are specific triggers. Now, one of those is the surprise question. We know that's not perfect, but it gives a nice quick way of people thinking about who might we be thinking about discussing at a needs rounds. Other kind of triggers to bring somebody along hopefully shouldn't come as too much of a surprise, some of them. So, you know, if you're seeing somebody that's got a significant decline or exacerbation in symptoms, then that's a good reason, good trigger to bring them along to discuss. If there's no plans in place, no advanced care planning, then to get ahead of that. Now in the UK, what we've seen since COVID is that that's so much better in care homes. So typically those are now pretty solid, which is lovely. This checklist was published way pre-COVID, so that's not been sort of updated in it. Number 4, conflict with the family around treatment goals of care and treatment decision options. So that often comes up because what people in care homes will often tell you is that you know, your resident Margaret might well have 2 daughters, and one of them wants mum transferred to hospital no matter what, and the other one thinks that actually the place of care should always be the care home. So quite often care home staff will get into discussions, you know, maybe mum's had a bit of a fall, maybe she's had an exacerbation of some symptom, and then the family are warring with each other or potentially warring with the staff about this should happen, no, this should happen. So conflict around that is often a really good trigger to get some to identify a resident, to discuss at a needs round, so that there can be a common understanding about what's going on for the resident and what disease progression might look like, what kind of conversations might need to happen, and what the affordances and negatives of transfer to hospital might be. So conflict with family becomes one of the important triggers. And fifth, of course, if somebody's transferred from hospital or some other setting for end-of-life care, then that would be an obvious trigger. I'm going to skip reviews because really that refers to when you've discussed a resident in a prior needs round. So let's just go to new referrals, assuming that this is a first time that you're running a needs round, and this is the stuff that you would go through. So as I mentioned on the previous slide, there's a bit of discussion about diagnoses, multiple morbidities, and so on, to get a bit of a landscape of that. To think about what their palliative care needs might be, and that might be physical, psychological, spiritual, and so on. And then to ask the staff, what are they most worried about? What are you worried about might happen if we don't get this right for this resident? What are the treatment goals? What are the goals of care here? And that can help elicit the exact focus for the discussion. So it's not just a kind of let's just talk about the residents and then we'll have talked about them, but so that there's a kind of purpose, and you're helping, or the specialist palliative care clinician is helping the staff really understand what would make a difference in the care. Some of it then goes on to mapping who else is involved, and of course that might then trigger conversation about lasting power of attorney and so on. And then, as I mentioned before, you'd weave in case-based education. So the number of times I've sat through and observed needs rounds being done where I've heard about bowel management, and the person from palliative care's sketched a, excuse me, on the back of it, literally on the back of an envelope, some anatomy and physiology of bowels and bowel obstructions and overflow and that kind of stuff. So that kind of stuff comes up quite frequently, as do other topics like communicating with families about prognosis and about symptoms and deterioration and so on. So those kind of things that the specialist palliative care clinician is bringing in some of their expertise from their setting and sharing that with the staff, usually based around, tell me what you already know. So there's a very respectful start to that, and then layering on other bits and pieces. So it's a kind of Lego brick kind of construction, like let's see where your starting point is, and then think about what other bits of information and bricks we can add into that to help you care for this resident, and then also other residents that you're looking after too. To make sure that it's not just talk, no action, the end of the checklist prompts people to specify what it is that they're going to do next. So you'd expect during the needs round for somebody from the care facility to be making notes in the resident's file about what's been discussed and what's been agreed. And you can see some examples here of the kind of things that happen, quite often deprescribing rather than additional medicines. But those kind of things. Sometimes, somebody might have a pacemaker with a defibrillator in it, but also say that they're not for resuscitation. So you might imagine there'd be an action to refer to cardiology or something like that. And of course, that final bit about refer to specialist palliative care, so that refers back to the previous slide where we were looking at one of the other components of the model is to get direct clinical input from the specialist palliative care team. So okay, so that's me zoomed back out of that. What I thought I'd do is play you a brief snippet of a video to show you what these look like in action. And if all goes well, I can make this big enough that you can see there's captions pop up within the video that tell you which bit of the checklist somebody's attending to at the time. The video we made in Australia a few years ago, they're real care home staff, not actors, but they're talking about a sort of fictionalized resident. They're all in their blue uniform. What you'll also see is a woman in red. She is a fantastic palliative care clinician who we're working with on the trial in Australia. So I'm going to click on this and hope for the best. Okay, let me zoom in again.
Thanks everyone for coming today, and thanks for being on time.
So it looks like it's not going to let me zoom in. Again, this is teething troubles with a brand new computer, so I think it's good enough to. I think it's good enough to see. I can see it. Please play. Oh, okay. Thanks, whoever that was. I very much appreciate the intervention there. So I'll zoom along to start at 2:16. We'll watch it for a few minutes, and then I'll stop it.
It's really important that we are respectful of each other and get.
Oh, it's not going to let me zoom along. This is very embarrassing. I do apologize. Right, usually I would play this from a couple of minutes in, but we're going to just wing it with whatever's at the start of this. Because I don't think it's going to let me actually see controls despite it saying it will.
Get here on time. Thank you, and for choosing the people to bring to. Firstly, why do we have these meetings? What are we trying to achieve?
Identifying residents who are in the last months of life.
With our blend in place.
Yeah, you're right. We know that if we recognise deterioration and dying and plan for it, residents will have a better outcome. What are you thinking about when you bring someone to this meeting? What are the triggers, and how do you choose people to bring to the Palliative Care Needs Round?
I wouldn't be surprised if the resident die in the next 6 months. Physical and cognitive decline, exacerbation of symptoms, and lots of transfers to the hospital with not much benefit.
Yeah, that's right. And also transfer back from hospital, actively dying.
Conflict with families around goals of care and treatment and care options.
Yeah, that's a big one, isn't it? We often have problems around setting goals and planning when families have conflict around the goals of care or the treatment plans.
No plan in play, not advanced care, and medicine.
Yeah, you're right, and I'd even go as far as say effective advanced care plan. Is it, what I mean by that is it up to date? Does it reflect the goals of care of today? Has it been filled out by the right person? Was the person that's done it, are they competent, or is the right alternative or legally appointed alternative decision maker been appointed and done that? Does it let us know where the resident wants to be cared for, and also their preferred place of death? These are all really important things. It's always such a pleasure just to hear that you know so much and that you've learnt so much. So well done. You're doing great. Who do you want to talk about first?
This case, Beryl, she's 92 years old and she had heart failure.
And what triggered you to talk about her today?
She's not eating or drinking that much, and she had difficulty breathing, and I think she had a bit of dementia. I'm worried about her.
So you're concerned about her breathlessness, her oral intake, and her general deterioration. Would you be surprised if she died in the next 6 months?
No.
Do you think she can make decisions for herself?
Yeah, she is adamant that she doesn't want to go to hospital again. She's tired and isn't scared of dying. Her daughter keeps telling her she has to keep trying and she needs to go to hospital to get better.
Who's her legally appointed alternate decision maker, and who's her family?
Her daughter and son have joined enduring power of attorney, and they can act together or separately. Her son is currently in Japan right now.
Does she have an advanced care plan?
No, she doesn't. Yeah, and a couple of weeks ago, she couldn't breathe, and the agency staff member called the ambulance. And because we don't have anything in place to make her comfortable, so we have to send her to the hospital.
She went to hospital when clearly she didn't want to. That must have been really hard for all of you and her. Okay, let's see what we can do for Beryl and you as the team, so that we can get a better plan in place. So you're worried about her breathlessness?
Okay, so I'm just going to stop it there because they continue to talk through Beryl and a few other people, but you get a sense about the kind of holding of the complexity and recognizing what a great job the team are doing, and actually how hard some of these dilemmas are, particularly when there's kind of differences in opinion about going to hospital or not, and so on. So that's what it looks like kind of in action. I'm going to talk a bit about the research evidence that we've accumulated. So we've basically done a ton of studies on this, all sorts of different designs and different populations. So we started off with a quasi-experimental study looking at what happens in terms of hospitalizations when we start using needs rounds. Then we moved to this ethnography where we generated the checklist, and that was based on a huge number of observations of needs rounds in Australia. Then we moved to the stepped wedge randomized control trial. That's where our main outcomes come from. So the stepped wedge design, for those unfamiliar with it, is a very quick way of giving yourself a massive headache. So it's sort of like a traditional randomized control trial where some people get it and some people don't, and you measure various things that you're interested in, like hospitalizations, length of stay, quality of dying and death, staff capability to take care of people at the end of life, and various other outcome measures that we were interested in. But it differs from that as a straightforward design in as much as everybody starts in control, and then bit by bit they roll into the intervention group. So we did this facility by facility. So we started off, I think we had 12 facilities with about 1,700 residents in total. So they all started off in control, and then we moved 2 facilities at a time into the intervention. So they started getting it, and then a month or 2 later, we introduced another 2 from the control group who got it, and then we could track all of them over time. So that enabled us to hold that kind of ethical position of not preventing people from getting the intervention when we knew from the initial quasi-experimental study that it was helpful. Enabled us to hold that ethical position whilst also measuring baseline and follow-up, and then following people over the course of about 18 months of the study. So we'll come on to some of the outcomes from that, but basically it's a thumbs up on all of the outcome measures we were looking at. At that point, I moved over to the UK and we set up an implementation science study here. So the idea for that was to say, well, okay, we know it works in Australia, and although the UK is a bit different, it's also quite similar. So what would it look like if we ran it here? So implementation science tends to try and understand what works for whom, under what circumstances, and why. So that was the question that we came to the UK with, and what might it need to look like to take into account the UK context. There've been various other bits and pieces of studies too, some of which I've been involved in and some I haven't. So telehealth, so during COVID, could it be delivered online? And some colleagues in Australia did a study there, and yes, it can, it's absolutely fine. So initially it was set up as a face-to-face model, but actually really easy to do over Teams or Zoom equivalent. And of course, that means that not just with COVID, but with all sorts of other norovirus type things that are frequently and have always cropped up in care homes, that there's not any bar to continuing with these. And we've looked at rural delivery, and other teams have looked at comparing how does it work if you put in a GP rather than a specialist palliative care clinician to deliver the intervention. And there was a study done in Adelaide, and they discovered that actually you can't really delegate this to a GP because it didn't work as well. So that was useful learning. So the outcomes from this, well, the infographic kind of is the key headline for commissioners, really, is that it's about £1 million saving on people not having as many admissions or shorter admissions to hospital. And of course, we're not all commissioners here. Of course, actually what that then leads to is better quality of care, better quality of life and death, and enabling people to die in their preferred place. So if you scan through these bullet points, you'll see the hospitalisation and cost saving data is those first 3. And then we move on to the ones that actually maybe we're as people delivering and people researching palliative care were actually motivated by. So better quality of dying and death amongst residents. That was a measure completed by care home staff. And as I say, we've got baseline control and then all the way through follow-up. The longer we ran this intervention, the stronger the outcomes were. So quality of death improved a little bit to start with, and then the longest facilities were in the treatment condition, receiving palliative care needs rounds, the better the outcomes were there. Staff got better and more confident at delivering end-of-life care. There were pre-COVID, there were more advanced care plans being completed. We've not seen that happen in the UK because we were running that during and then after the initial COVID lockdowns. And preferred place of death improving there too. So lots of really, really positive outcomes. So these kind of Brumfer ecological systems model type model, just kind of spelling out really that there are benefits for all of these. The residents, yes, better quality of life and death. Relatives were reporting to us. We tried to ask them to complete questionnaires. They were not into that, but we did follow up with interviews, and relatives were really clear that they thought that their relatives would get the person living in the care home was getting better care. Better, as I say, they felt more confident. Specialist palliative care teams, so they really enjoyed the building up of a trusting, close working relationship and feeling like they were getting ahead of things and doing this proactive care and planning. Primary care, so GPs were reported, and care home staff reported that actually communicating with GPs was much better. They had a wider, richer vocabulary for describing their concerns about residents, which led to much more prompt responses from primary care, so that changes in status could be looked at immediately. And of course, acute care services in terms of that cost saving. The cost saving Joanna's asking about in the chat. So we ran that RCT in it was Canberra, and like I said, that was 1,700 care home residents, which was just like a dozen care homes. They're much larger in Australia. So I think the average care home occupancy in the UK is about 45 or something, and in Australia it's closer to 90, and we had some facilities that were 160 residents, and of course people die quite frequently, so a care home at the start of the study had a different population to later on. So there were, it was a small geographic area, but quite a lot of people involved in it. So UK implementation occurred sort of way up in the Highlands to down south in Surrey. This is our team, including people with lived, as lay members of the team, Margaret, Maisie and Irene here, and the rest of us academics, but also with many of us family members living in care homes. From the implementation science study, we generated this, what works for whom, under what circumstances and why. And again, I'm going to attempt to zoom in on this little jigsaw puzzle. So not a very subtle metaphor about pieces of the jigsaw fitting together, but here we go. So you can see the impact on care home staff, enabling them to kind of communicate better, care better, keep everybody kind of happier and more confident, and able to do what they need to look after people well. My mouse has now disappeared. There it is. Staff confidence, enabling them, whether or not that was face-to-face or through telehealth, to use the needs rounds, and some little quotes from some of the staff that were involved. It really helps with the interdisciplinary working. So obviously, you've got people from the hospice coming in, but like I say, that had really nice knock-on consequences for other interdisciplinary care, including the ambulance service, pharmacy, primary care, and the acute sector, all leading to better lives and deaths, which is what it's all about. And as I say, we didn't get questionnaires back from families, but the qualitative data was really clear that families felt much better supported, and that the education that happened within the care homes, some of that then flowed through into how staff were communicating with resident families. So a few quotes for those of you more qualitatively minded. So these are quotes from the UK study. I'll not read them out, but give you a chance to kind of scan through those. Although if anyone's got visual impairment and would prefer that was read out for themselves or from a colleague that they want to advocate for, then please just speak out and I will do that. So you can see there's kind of key themes woven all the way through that. Excuse me. So lots of positive reinforcement for us that this was working as well in the UK as it did in Australia. So all round, as that kind of ecological systems model shows, we've got benefits for staff and all categories of staff within the care home and then beyond the care home. The benefits accrue not just for the people discussed in the care home. So if you've got a care home of 40 people and 5 of them never get discussed, actually what you do see is that better quality of life and death happens for them too, and reduced hospitalizations for them too. So the benefit in having these conversations and the education reaps rewards beyond just those that are discussed. In the UK, monthly is probably a bit too frequent because of the smaller size of care homes. But crucially, it does take time to set up these relationships between specialist palliative care and care homes. You don't get the great benefits immediately, and it takes a while for people to kind of hit their stride with how to run them themselves rather than how we think they should be run, or sort of doing it per protocol, if you like. So we've published loads on this. You don't need to look at that for too long, but I do need to show you who funded the work so that I do not get told off by them. So that's come to the end of the surprising slide share, given that was not the set that I was updating yesterday. I'm just going to drop in the chat a link to our website. So what you'll find there is a whole bunch of information and resources, publications linked, and the videos and sort of quick start guides to how to get going with palliative care needs rounds. So I'll pause there and see whether or not there's any questions or queries or challenges or experience. Oh, and hello to Julia in Germany. How are GPs involved in care in the needs rounds? So the ones that we ran in Australia in the trial and the quasi-experimental and in the UK, GPs were not directly involved. So the part 1 of the needs rounds model of those triage meetings is just somebody from the hospice with care home staff. So GPs get involved typically at the end of the meeting if there's a need to loop in primary care about maybe a change that is requested or a change that wants to be communicated. Yeah, so they tend not to be in the mix. And we've looked at, in fact, with the UK implementation science study, there's something about in some areas where GPs have monthly rounds with the care home, whether or not the two can slot together. And absolutely, if that feels like that's going to work in a specific practice setting, then absolutely go ahead with that. I should say we are not precious at all about this. Like, if you want to pick it up and tweak it, go right ahead. Like, absolutely, the absolute core impetus is let's improve care. So GPs tend not to be involved, and it hasn't worked when we've asked them to be the clinical leads. But there's no reason to say that actually it couldn't be involved in other core clinical meetings that happen. In what way does assisted dying have an effect on the process of delivering care? Well, in the UK, of course, assisted dying is not within law. So I guess that's a kind of future focused question about what that might look like. And I guess, you know, most of the legislation in the UK, Scotland's got some paperwork going through Parliament, is slightly behind where Westminster's at. So I guess in most jurisdictions, it excludes specifically people with a longer prognosis and or with cognitive impairment. So it almost certainly won't impact direct care delivery or how needs rounds are delivered here. In Australia, the places where we were testing it and trialing it, assisted dying wasn't available. It has since been included in legislation elsewhere in Australia, but it wasn't at the time when we were doing these studies. So it's the same sort of thing, that it just wouldn't been within legal practice. Thanks, Ivy. Where are you based, Ivy? Saying it's the same in your country. Be interested to know. Singapore. Right, okay, interesting. And then I can see hands up, and now I've sort of taken over chairing when I should probably shut up. I'll hand over to you, Emma.
No worries. So I think what I'll do is I'll go first to Therese, and then to Claire, and then I think very, very exciting and very like to my question as well as Joanna Davies is the what's next. So should we go to Therese first?
Thanks, Amel, and thanks, Liz, for this presentation. It was really, really good, really interesting. So I have a question regarding kind of how this is different or distinct from advanced care planning, and especially since some of the triggers, and I recognize this from my own work, where you have conflict within the family regarding like what's going to happen, and are there can the needs rounds lead to family being invited to have like a more like a family conference, and how is that a very general question regarding the kind of similarities and maybe also differences between making advanced care plans involving family and these needs rounds.
Yeah, absolutely. So yeah, one of the outcomes is certainly in Australia often was, let's bring in the family and let's talk to the family. Let's think about where there's a difference in opinion and talk through where that's come from, and how we might think about coming together and having a kind of shared understanding about what might happen. So the future care, sorry, in Scotland, we're now calling it future care planning. So advanced care planning and future care planning. So there might well be conversation about that with the family. I would say future care planning is sort of implicitly woven through the needs rounds triage meeting, because it is all about what do we need to have in place. Now, not all of that needs sort of documenting, because some of that is about staff knowledge, staff confidence, that kind of thing, rather than what needs documenting in the person's file, if you like. But yeah, the two kind of, they weave together.
Thank you, Liz. Claire, would you like to ask your question?
Sorry. Firstly, thank you so much. I really love this work, and it's clearly making such a difference to the care provided and delivered. So thank you. My question is, and you touched on it already, is about the people who aren't routinely brought to the needs rounds, and you already mentioned that actually they get benefits as well, presumably through the education that's provided to the staff. Were there any ever concerns that individuals were never being brought, or there might be kind of people who were very silent and didn't seem like there may be problems, but might have underlying problems or anything around that? I'm just quite interested in how we identify needs for individuals, particularly people who are not verbally communicating.
Yeah, oh, what an interesting question. So I don't know. It's that unknown. So, but I don't think there was much of a risk of missing people. And that's because when we set up the needs rounds, we asked to meet with various members of the team, and then for information about the needs rounds to be cascaded across the organisation. And one of the things that we tried to ask people to do was to stick a bit of paper up on the staff room wall saying, who should we discuss at needs rounds? So that everybody had a fair pop at putting up somebody's name. So that might mean the activities coordinator might have noticed that somebody was moving differently, might have been somebody from the kitchen had noticed that somebody wasn't eating as much or differently. So I'm relatively confident that we might have caught everybody directly, but I don't know.
I really like that everybody was involved in that, though. So it could be anybody, whether it was kind of the person coming in to clean a room or
Yes.
whoever could be identifying. And could any of those people attend the needs rounds, from kind of an education perspective?
Yes. And actually, we actively encourage that. It was often down to the manager of the care home to decide who would attend. But we'd say, can we have their key worker? Can we have whoever's most likely to have insight into this? So yeah, and we were very, very welcoming of ever changing, every month it being different people in the room, and that was fine. It brings quite a nice energy actually, because you're building relationships with multiple people rather than just a kind of one-to-one type thing.
Thank you. I've actually got lots of questions, but I suspect other people have lots of questions too. So I'll it's just really, thank you. Really interesting. I'll hand over to other people.
Thank you, Claire. It kind of ties in well because you're already talking about how the meetings work. Joanna's question about how did the teams manage discussing 5 to 10 patients in a meeting? How did they like it? How did they find that experience?
Yeah. So it takes a bit of getting used to. And one of the, again, apologies for that PowerPoint not being the one I worked on yesterday. If we'd started the video at minute 2:16, as I'd hoped, what you would have seen was about 5 minutes where they do work their way through one resident, and it's very fast paced. So there is something about how the meeting is chaired. Okay, who have you got for me next? Which of the triggers do they meet? Tell me about this, and this. What are your concerns? And so it's very, very speedy. It's really different to how hospices are used to working, where they might have 90 minutes to talk about one resident. And we've certainly had palliative care clinicians reflect with us, these care homes are looking after residents who are as complex as people we have in the hospice, and they're doing everything in a heartbeat, turning on a dime, and they're out. And we would spend hours discussing and debating. So it is a bit of a shift. But yeah, 5-6 minutes per resident and a bit of time at the start and end just to kind of settle and then wrap up. You hopefully saw in that clip that there was somebody sort of typing notes as they went, so that helps with keeping things paced too, that everything's being done sort of synchronously.
Thank you, Liz. I'm just wondering, in line with Anna Bone's question in the chat, you mentioned a few times that it takes time for teams to get used to working in this way. I'm just wondering how long, and Anna's question being, how did you found engaging care homes and specialist palliative care teams in this research and changing their practice? What are some concerns about resource implications? So if you could just talk to us about that a bit.
Yeah. Oh my goodness. Oh, the stories I could tell, Anna. And are you the same Anna that I was citing earlier about the care home death data? Yes. Oh, lovely. Hello.
Yeah.
Hi.
Okay. So in some respects, it was enormously painful. It was really tricky getting care homes on board. Less so in Australia because the relationship had already been developed by the time we got to the trial, and because they knew that what we were trying to do was something that had never been done before there. I mean, I know people trying to support people in care homes is not novel, but how we were kind of thinking about how different that would be to their usual care. So that was a bit of an easier win. The UK, we set this study off in October 2020, where we were out of the first lockdown and just nosediving into lockdown 2 or 3 or whatever it was. It was horrific. And I've got literally shivers going through my spine having to think about that. So that was tricky. Because they were obviously so overwhelmed with just routine clinical care and not finding that clapping was adequate to support them in their work. I think the resource implications at this point now are that while this is free for care homes, unlike other models like gold standard framework and so on, where there's a sort of payment required, this is all free for them. The resource stuff comes in at commissioning level for specialist palliative care units, who, as you know, are probably 30% core funded by government or local councils, and then the rest of it is out of charity, pretty much. So the resource implications there, what it means, I think, is some really hard conversations with chief executives and with boards of hospices about where they put their service. And that's not a conversation that anybody really wants to have, because we know most of that service is going to people in the community living in their own homes. There's some in the bricks and mortar of the hospice, but actually, given what we know about the epidemiology and the likely place of death, the resource implications lie on services like palliative care teams to think about equity and to reshape that. So anyone that wants to pick that up with somebody they know in hospices, please do. So I'm not just a single voice.
Thank you so much. That sounds like it was very challenging. I am aware of time, but I would really love to hear a bit more about what's next. What are the plans? Is there a national rollout? Do care homes that were involved in UK, Australia, did they carry on with the model? And there's a very quick question in the chat, which I think is like, were there one care home or multiple care homes joining in the same meetings in the virtual ones? So if you could just quickly tell us about those, and
Yep.
then I will have the closing remarks. I think it's very evident that it was a brilliant talk because we could chat and ask questions for 2 more hours.
Yeah, brilliant. Well, yeah, and thanks for being so lovely in your feedback. So what next? So I'm basically going around like a very bad salesperson, trying to pitch this to people. We're going to have a roundtable discussion with ministers in Scotland and with other key partners. One of the Scottish ministers has agreed to put forward a members' debate on care homes and raise this. I'm trying to lobby that this is given as an example in the Scottish Palliative Care Strategy, which is just under consultation stage at the moment, and doing similar things with Westminster and colleagues in England. But it needs that high level, it needs a systemic intervention, I think, because the piecemeal stuff is too problematic because it comes down to sort of localities. In Australia, the sites that were used in RCT, so they're still running with it. They've adapted it, they have changed it, and they're all glad that we're not pestering them with spreadsheets anymore. Less so in the UK because the commissioning setup is a bit different. Although one of our sites is just developing needs rounds to use with their prison care population as a way of triaging and working with them and having a kind of clear model of it. So it's kind of morphing and evolving in a really exciting way. And more than one care home at the same time. So that makes me think a little bit about the ECHO model, which is more based on staff education and case presentation. So we've not done that, but there's no reason to say why that couldn't also be one of the evolutions. And especially for whoever it was in the chat was saying that they had loads of different 25 care homes that they're looking after, then that might be one way, as long as you can preserve people's anonymity and confidentiality, which obviously, you know, we all need to keep a careful eye on. But yeah, thank you so much, everybody. It's been really lovely getting a chance to blather on about it.
Thank you so much for a brilliant presentation, and once again, thank you for agreeing to share the slides with us, the version that you would like, and we will have the recording ready as well. And I'd like to thank everyone for attending, and if possible, I would like you to invite you to unmute and give a round of applause for Liz. So thank you so much. Before we have one more minute, so I'm aware that someone's trying to clap virtually. So my colleague will pop in the chat an evaluation form. It only takes a few minutes. Please do complete it if you get a chance. To stay up to date with our program, please join our mailing list. Our upcoming seminar is going to take place on the 26th of February, and our very own Professor Irene Higginson will be presenting their work with the interdisciplinary Better Health and Care Futures initiatives. I'm sure it'll be really interesting. But yeah, thank you so much once again to everyone for joining, and thank you once again to Liz for presenting.
Okay, cheerio, bye.
Thank you.
Thank you.
Bye.
Bye. Have a nice evening
Thank
or
you. Thank you.
day. Thank you.